Welcome to the deep dive. So glad you could join us.
Great to be here. Let's dive into a moment that really shifted the landscape of cancer treatment. Imagine being diagnosed with metastatic melanoma, the most serious type of skin cancer, back in the late 2000s.
Yeah.
At that time, it was a rapidly rising diagnosis, and for many, it came with a deeply unsettling prognosis, especially once it had spread. If you had stage IV disease, the median survival was tragically less than a year. And critically, if your initial treatments weren't working or stopped working, the options available were incredibly limited.
That was a difficult place to be.
Yeah, often leaving clinical trials as the main path forward because there simply wasn't much else that offered, meaningful hope for long-term survival.
That's absolutely right. It was a time of significant unmet need for these patients. Standard approaches, while sometimes providing maybe temporary control, rarely translated into durable remissions or extended lives for those with advanced disease that had progressed.
And that brings us to a pivotal publication in the New England Journal of Medicine from August 2010. This wasn't just another incremental step forward. This paper presented data from a study that dared to try something fundamentally different.
Yes, this deep dive is focused entirely on unpacking this specific phase 3 study. It tested a completely novel concept for this patient population, not targeting the tumor directly with traditional toxic therapies, but instead unleashing the power of the patient's own immune system to fight the cancer.
So our mission in this deep dive is to guide you through exactly what this study did, what incredibly significant findings it uncovered that truly changed how we thought about treating melanoma, and just as importantly, what the trade-offs were in terms of potential risks and side effects. And we're going to do all of this based only on the information, the data, and the insights presented right here in this foundational paper.
So stepping back to that difficult landscape before 2010, as you mentioned, treating advanced melanoma was a major challenge. It's an aggressive cancer, and conventional therapies really struggled to provide durable control or significantly improve survival rates, especially in patients whose disease had advanced after prior treatment.
Right, patients who had already received one or more systemic therapies and whose disease had progressed were in a particularly tough spot. But in parallel, scientists were gaining a deeper understanding of the intricate relationship between our immune system and cancer.
And a key insight from that research involved identifying what are called immune checkpoints.
Okay.
These are molecules on immune cells, like T cells, that act as critical regulators. They're supposed to prevent the immune system from going haywire and attacking healthy tissues. But cancer cells can sometimes exploit these checkpoints, essentially putting a leash or a brake on the immune response that should be targeting them.
Okay, so the study we're looking at focused on one specific checkpoint called cytotoxic T lymphocyte-associated antigen 4, or CTLA-4. Walk us through that. What exactly is CTLA-4 doing in the immune system?
Well, think of CTLA-4 as a key inhibitory molecule, a brake on T cells.
Right.
T cells are the workhorses of our immune system, responsible for identifying and destroying abnormal cells, including cancer cells. But when CTLA-4 is engaged, it essentially dampens their activation and limits their ability to proliferate and mount a strong attack.
So if CTLA-4 is putting the brakes on, the idea behind the drug tested in this study of Ipilimumab was to release those brakes.
Exactly. Ipilimumab is a monoclonal antibody designed specifically to block CTLA-4. By blocking this inhibitory signal, the goal is to unleash or activate the T cells, allowing them to build a stronger, more sustained attack against the melanoma. The paper describes this as potentiating an anti-tumor T cell response.
Now, the study design wasn't just Ipilimumab versus nothing. It also included a vaccine arm.
Yes, they used a glycoprotein 100, or GP100, peptide vaccine. This was a known melanoma vaccine at the time, and in this trial, it served as an active control group.
Active control meaning not a placebo.
Right, meaning patients in the control group received a treatment that was already in use rather than just an inactive sugar pill or saline infusion. Previous studies had shown the GP100 vaccine could induce immune responses, but had limited success on its own in actually shrinking tumors.
Okay.
It's also notable that this specific vaccine strategy relied on patients having a particular genetic marker, HLA-A0201.
Oh, okay.
Think of HLA as a presentation tray on immune cells. The vaccine needed that specific tray type to effectively present the GP100 peptide and stimulate an immune response. This is why being HLA-A0201 positive was an eligibility requirement for the study patients.
Right, makes sense.
Although the mechanism of Ipilimumab itself isn't restricted by HLA type.
Okay, that clarifies why the HLA type mattered. So they had this completely different idea, release these immune breaks. How did the study authors go about designing the experiment to really test this hypothesis effectively?
They set up a phase 3 randomized double-blind trial, which is considered the gold standard for evaluating new treatments. It was quite large, conducted across 125 centers internationally.
And who are the actual patients they brought into this study?
They enrolled 676 patients with unresectable stage 3 or A melanoma. And remember that tough population we talked about?
Yeah.
Crucially, these were patients whose disease had already progressed after receiving at least one prior systemic therapy for their metastatic melanoma.
So not first line.
Definitely not first line. This was aimed at a group with limited options. And as we just discussed, they also needed to be HLA-A0201 positive because of the GP100 vaccine arm.
Got it. And how are these patients then divided up to receive treatment?
Patients were randomly assigned into 3 groups, but in a specific ratio to ensure more patients received an Ipilimumab-containing treatment. It was a 3.1.1 ratio.
Okay.
So 403 patients received Ipilimumab plus the GP100 vaccine, 137 received Ipilimumab alone, and 136 received GP100 alone as the active control. Randomization helps balance patient characteristics across the groups, making the comparison fair.
What was the treatment schedule like for these groups?
Patients received Ipilimumab, or a placebo infusion, at a dose of 3 milligrams per kilogram of body weight. This was given intravenously every 3 weeks for up to 4 initial induction treatments.
Okay, 4 doses.
Right, for the induction phase. Those in the vaccine arms also received the GP100 peptides injected under the skin after their infusion. The study also allowed for the possibility of reinduction therapy with Ipilimumab if a patient had initially shown stable disease or a response but later progressed.
There's also a notable point about what the study was primarily trying to measure as its definition of success. Something changed.
Yes, this is an important detail mentioned in the paper. The study protocol was actually amended during the trial to change the primary endpoint. It shifted from looking at just the best overall response rate, meaning how many tumors shrank,
Right, tumor shrinkage,
to focusing instead on overall survival.
which is a bigger deal.
Absolutely. Overall survival is a more definitive measure of clinical benefit because it directly answers the question of whether a treatment helps patients live longer, which is ultimately what matters most.
And beyond overall survival, they measure things like response rates, how long those responses lasted, progression-free survival, and critically, safety.
Precisely. The whole package.
So they designed this rigorous trial, enrolled this challenging patient group. What happened when they actually gave the treatment? What did they find when they released the brakes on the immune system in these patients?
The results, when they were published in 2010, were really quite groundbreaking for the time. The main finding was clear. Ipilimumab, both when given alone and in combination with GP100, significantly improved overall survival compared to receiving the GP100 vaccine alone.
Okay, let's look at those key survival numbers directly from the paper. What was the median overall survival in each group?
Right. So for patients receiving Ipilimumab plus GP100, the median overall survival was 10.0 months. For those receiving Ipilimumab alone, it was very similar at 10.1 months.
Okay, about 10 months.
Now, compare that to the control group who received GP100 alone, where the median overall survival was just 6.4 months.
Wow, okay, so roughly a 3 to 4 month increase in median survival with Ipilimumab. And the hazard ratios quantify the reduction of the risk of death.
They do. The hazard ratio for death was 0.68 for the Ipilimumab plus GP100 group compared to GP100 alone.
Meaning about a 32% reduction in risk.
Roughly, yes. And it was 0.66 for Ipilimumab alone versus GP100 alone.
So even slightly better there.
A little bit, yeah. These numbers, both significantly less than 1, indicate about a 1/3 reduction in the risk of death for patients treated with Ipilimumab. The paper notes the p-values were less than 0.001 and 0.003 respectively, meaning it was statistically significant, essentially ruling out that this survival difference was just due to random chance.
What really stood out, especially considering the historical difficulty in treating these patients, were the longer-term survival rates presented in the study.
Yes, this was a major point. The 1-year overall survival rates were approximately 44% in both Ipilimumab groups,
44%.
compared to about 25% in the GP100 alone group. And even at 2 years, the survival rates were still around 23–24% for patients who received Ipilimumab versus about 14% for those who received GP100 alone.
So nearly double the 1-year survival and still a substantial difference at 2 years.
Exactly. For a patient population where survival beyond a year or two was historically uncommon after prior treatment failed, these rates were incredibly encouraging and, well, new.
And comparing the two Ipilimumab groups, the one with the vaccine and the one without, Adding the GP100 vaccine seemed to make a difference in overall survival?
No. The study found no statistically significant difference in overall survival between receiving ipilimumab alone and ipilimumab plus GP100. The hazard ratio comparing these two groups was 1.04 with a p-value of 0.76.
So basically identical outcomes.
Pretty much. This finding strongly suggested that ipilimumab was the component driving the survival advantage, and adding the GP100 vaccine didn't provide an additional overall survival benefit in this trial.
The paper also looked at progression-free survival, how long patients lived without their disease getting worse. What about that?
Right. So while the median progression-free survival numbers were initially quite similar across the groups, the curves representing the groups did separate over time,
Okay.
particularly benefiting the ipilimumab alone group, which showed a greater reduction in the risk of progression compared to GP100 alone, and even slightly better than the combination arm.
What about shrinking tumors? Were there high rates of patients seeing their tumors shrink or disappear? Because survival improved, but maybe not always through tumor shrinkage.
That's a great point. The overall response rates, meaning patients who had a complete or partial tumor response, were relatively low compared to what you might see with some conventional therapies. They were 5.7% for the combination, 10.9% for ipilimumab alone, and only 1.5% for GP100 alone.
So, not huge numbers responding in that way.
No, but the disease control rate, which includes patients whose disease remains stable, was higher around 28% in the ipilimumab groups versus 11% with GP100. So more people had their disease sort of held in check.
And there's a really interesting observation about the timing and duration of those responses in the ipilimumab groups that seemed different.
Yes. This was a key piece of the puzzle, different from how many other cancer treatments work. The study noted that tumor responses could actually improve or even appear months after treatment started, even after week 24.
After the initial 4 doses were done.
Yeah, potentially, which is unusual compared to typical chemotherapy responses where the effect is often seen earlier. This really hinted at a delayed, ongoing immune-mediated effect.
Right, the immune system taking time to ramp up.
Exactly. And importantly, the responses that were seen were often durable. A significant proportion of responders in the ipilimumab alone group maintained their response for at least 2 years, according to the paper. They also noted that some patients whose disease had progressed after the initial treatment course could see a clinical benefit if they received reinduction therapy with ipilimumab.
And did these benefits seem to hold true across different types of patients in the study, like older versus younger, men versus women?
Yes, the paper reported that the overall survival benefit seen with ipilimumab was consistent across the major subgroups they analyzed. This included patients of different ages, sexes, disease stages, with varying levels of LDH.
What's LDH again?
Lactate dehydrogenase. It's a blood marker sometimes associated with tumor burden or prognosis in melanoma.
Okay.
So yeah, consistent benefit across LDH levels, and also whether or not they had previously received IL-2 therapy, which was another earlier type of immunotherapy.
So we've got a clear, significant survival benefit shown for the first time with this immune-based approach in a patient group with a critical unmet need. But as you hinted earlier, unleashing the immune system in this way comes with a very specific set of challenges, side effects.
Absolutely. This study was equally critical in helping us understand the unique pattern of side effects associated with this mechanism. These are called immune-related adverse events, or IRAEs.
IRAEs?
And they result from the activated immune system attacking healthy tissues as well as the cancer.
How common were these immune-related side effects in the study?
Immune-related adverse events were the most frequently reported side effects linked to the study drug. They occurred in about 60% of patients treated with ipilimumab.
60%, wow.
Compared to around 32% in the control group getting the vaccine.
And what about severe side effects? That's often the major concern, grade 3 or 4.
Yes, severe, meaning grade 3 or 4 immune-related adverse events, occurred in a notable proportion of patients between 10 and 15% in the ipilimumab-treated groups.
10 to 15%. And the control group?
Much lower. Only 3% in the GP100 control group experienced severe IRAEs.
Where did these IRAEs most commonly show up in the body? What were they seeing?
Based on the paper, they most often affected the skin rashes, itching, and the gastrointestinal tract.
Like diarrhea?
Yes. For example, diarrhea was a very common specific IRAE reported in 27–31% of patients in the ipilimumab groups. Colitis, which is inflammation of the colon, was also a significant one.
How were these side effects managed according to this study? What did they do?
The study emphasized the importance of prompt medical attention and the early use of corticosteroids.
Steroids, okay, to calm the immune system down.
Exactly. Steroids are anti-inflammatory medications that can dampen the immune response, causing the IREs. They noted that for grade 2 or higher IREs, the typical time to resolution was around 4.9 to 6.3 weeks with appropriate management.
This is where the critical trade-off comes into sharp focus. The study is very clear that these adverse events can be severe, long-lasting, and potentially life-threatening.
That's an absolutely essential point the paper makes. While the survival benefit was significant, the potential for serious and even fatal toxicity was a very real concern. The study reported a total of 14 deaths related to the study drugs across all groups.
14 deaths out of about 670 patients.
Right, which is 2.1% of the safety population. 7 of those deaths were specifically associated with immune-related adverse events in the Ipilimumab groups.
7 deaths directly linked to the immune side effects of Ipi. What kinds of events led to those fatalities, as described in the paper?
The paper lists severe examples, such as inflammation of the colon, the colitis that I mentioned, leading to bowel perforation,
Oh, wow.
multi-organ failure, a neurological condition called Guillain-Barré syndrome, and liver failure. These examples really underscore the potential severity when the activated immune system targets vital organs.
And even among patients who survived and did well long-term, some experienced ongoing effects. Not necessarily life-threatening, but still there.
Yes, the study noted that some patients who had sustained clinical benefit experienced ongoing or residual issues, although typically lower grade. These could include things like injection site reactions, changes in skin pigmentation, vitiligo.
Right.
Some continued low-grade gastrointestinal issues like diarrhea, and importantly, endocrine problems like inflammation of the pituitary gland, which required long-term hormone replacement therapy. Fatigue and rash were also mentioned as potential ongoing low-grade effects.
Okay, so let's really bring this all together based on what's in this paper.
Yeah.
What is the core message this 2010 study delivered to the medical community and to patients?
The core message is that this study provided definitive evidence that ipilimumab could significantly improve overall survival in patients with previously treated metastatic melanoma. For a patient population with such limited options, this was, well, a monumental finding.
It really was a pivotal moment, right? It validated the idea that targeting immune checkpoints could be a successful strategy to effectively treat cancer by harnessing the body's own immune system.
It absolutely did. It demonstrated that immune activation therapy could produce long-term survival in a subset of patients, a true breakthrough. However, as the comprehensive safety data in the paper clearly shows, this significant survival benefit came with a crucial caveat. The potential for severe, sometimes life-threatening immune-related adverse events is very real and requires careful management and monitoring.
A real double-edged sword in a way.
You could say that, yes. A powerful tool with significant potential benefits and significant potential risks.
And the paper notes that the study was funded and sponsored by Medarex and Bristol-Myers Squibb.
That's correct. Standard disclosure.
So, this study showed us that we could achieve unprecedented survival benefit in a tough-to-treat cancer by activating the immune system. But simultaneously, it delivered a powerful message about the potential risks involved when you unleash that system. Based on this study alone, with its clear demonstration of significant survival gains alongside the very real potential for severe, even fatal, immune-related side effects. Here's something for you to ponder. How did this foundational work highlight the ongoing critical challenge for researchers and doctors to understand not just how to turn the immune system on to fight cancer, but also how to best predict, manage, and potentially mitigate those complex, sometimes dangerous effects of that activation? It underscores the delicate balance needed to maximize benefit while minimizing harm when wielding such a powerful tool.
Thank you for joining us for this deep dive. We'll catch you next time.